A few no-shows, but I think it's time for us to get going. We're doing this on a streaming basis, so I don't want to hold up the thousands of people out there who are watching this on the internet. Anyway, I'm J.B. Silvers, for those who I haven't met before. It's so great to have you here. This is always a fun time. Although I have to say it's a little difficult as a faculty member to have you here. It's a bittersweet experience because it's so good to see people from previous years, but it causes huge cognitive dissonance in the faculty members because those of us who've spent all of our career in academia, we harbor the illusion, including myself, that since the students never get any older, we don't get any older either. And seeing you here just completely blows that illusion. It's just a really big problem. Anyway. No personal individuals, I might say. I'm not pointing at anybody. I used to think my hair was just light brown until I saw myself under one of these lights and realized that was not true anymore. Anyway, it's so good to have you here and dealing with this topic. And with my panel members as well, who I think you all know from the literature, Mark Votruba from the economics department. I'll let them say a little bit more about themselves when they start up. Who's done a lot of really great work with insurance, and we'll do some good background on that, I think. Mariana Carrera, who joined us, 2 years ago, something like that, and has done some, also from economics, and done some really neat stuff with dealing with the pharmaceutical business. And Richard Buchanan, who came 5 years ago, and he's one of our design gurus and has worked a lot with that whole theme of the school and has also worked with patient experience in a number of places with some of our teams. So he'll fill that out. What we'd like to do, I'd like to do an introduction, talk a little bit about what reform is, but particularly try to focus on where the world's going, since I know that was what we were trying to deal with in terms of this session, and then turn it over to them to pick up various aspects of what's likely to happen next. Hopefully leave a big chunk of time, maybe even half if we can do it, for questions and answers. So keep some ideas in mind, and we'll have some general interaction discussion as we go along. Okay? Anything that I say that's totally egregious, well, I guess you can interrupt. It's just like a normal class anyway. But we'll hopefully have plenty of time to pick up on those issues as well. So with that, let me talk a bit about where we're going to go. And I tried to give you the bottom line I guess I have to stand back here. In the handout that I have, and I hope everyone has the handouts. There are 2 or 3 more down here if you missed them, the final punchline. So I'd like to talk about these aspects of it. But before I do that, get into a little bit about what the market looks like, because this is really about insurance reform. Fundamentally, at this point, although I think what we're going to find is that the other parts of the reform law maybe are as important or perhaps even more important as this rolls out. So we're going to get into some of those issues as well. The healthcare reform bill, and some of you I know from other audiences have seen some of these, so I'm going to flip through them fairly fast, was basically about 2 things. Covering more people and getting those nasty insurance companies to stop doing the bad things that they do. And I have to say, as some of you know, I was CEO of a health insurance company for a while. It was very discouraging to have little kids make fun of you and people say bad words about you. No one loves their insurance company for good reason, because there's some issues. And so Mark's going to get into some of those things. So can we get them to do bad things, stop doing bad things and cover more people? The easy one was the kids who move back into the basement. And so if they're living in your basement anyway, why not put them under your family insurance policy? So putting kids on up to age 27, no-brainer, easy. Medicaid expansion, obviously a lot more difficult, and we can talk about that because there are major political issues with that, as well as perhaps some financial questions in terms of what happens with Medicaid expansion, but it's clearly an important part of what's going on. And then we get to things like the individual mandate, which is where the rubber hits the road in multiple ways. Now, this came out of some intense negotiations, otherwise known as deals. And some of you have seen this, but this is very important because I have an historical picture of the negotiating session where this was put to bed. It's very interesting to see because this is what it looked like. Now, you may think that I'm joking, but actually, when you look at this picture, you can actually identify all the players. The AARP is over here. You know it's AARP because they're little droopy, sort of sleepy looking, you know, they need their naps in the afternoon. Oh, listen, I resemble that. I don't have any trouble with that at all. All they wanted was to give them the drugs. Just get rid of the donut hole. They got it. They got it. They got the donut hole taken care of. We can talk it. Now, Big Pharma over here, you know it's Big Pharma because they got two forms of medication. Had to be Big Pharma. All they wanted was stay away from drug pricing and don't let those people import drugs from Canada. That screws up our whole market. They got that, okay? But in order to do the drugs for the old people, you had to get the drug companies to cooperate, and that's where the money came from to do the switch. So it was a part of a deal, and it worked. It stuck pretty much. Now the docs are sitting here. You know it's the docs because they got the cards really close to the vest, right? Had to be the docs. All they wanted was to stop messing around with that sustainable growth rate formula for those who are wonks out there, the sword of Damocles that says I'm going to cut your rates in Medicare each year by 27%, and then I don't do it. So it's sort of, you know, it's not really nice to do that to people, to threaten to cut off their legs and then say, oops, just kidding. That's what Congress has done every year. They want to get rid of that. They didn't get it. That's a biggie. The hospitals are sitting over here. They're pretty happy. They're leaning back. They got their cards. They're happy because all they wanted to do was get their uncompensated care taken care of. Just stop giving me people that don't have money. And if you get them insurance, that takes care of that. They got what they wanted. So they're pretty happy about it. The employers, they're off to the other side. Would that be right or left? I don't know. Depends on how you look at it. They were sort of out of it, except that that's important because they were in the game the last time around and were really negative. So except for the small business coalitions, the Federation of Independent Business, the Business Roundtable, the big businesses, they were pretty much at least tacitly supportive, if not positive on this. They certainly weren't negative. The insurance industry, now again, you know it's insurance. This is a dead ringer. Because they got those cards hidden down, they got the ace down there. Had to be the insurance company. They just wanted, they said, look, we'll stop doing bad things if you bring us more customers. It's simple. Just give us a bigger pool and it all works out. So they were happy with this, unlike the last time around when they were adamantly against it. So the insurance companies, they were pretty happy with the whole thing. And of course, Obama's sitting here. He had most of the cards the first time around. Doesn't anymore. So we have some issues with that. Now the point I want to make is this was a set of deals that were politically very much intertwined with each other and were essential to make this thing work. That's really interesting because I'm not a political scientist, but the fact that we managed to pull that off without major disruption. What you've seen since then is basically working around the edges, trying to get the regulations written in your favor. So, and by the way, the insurance companies are still the whipping boy, so we still make nasty comments about them. Because that's the way politics is played. But by and large, they were very supportive, and they still are very supportive in this whole thing. So now you know everything you need to know about healthcare reform. Okay, that's it, all in one picture. I was tempted to end this set of slides right here, and then I thought, nah, probably better spend a little more time talking about it. Because the one really key one that never got discussed was the subsidies. These are the two subsidy levels, and they never got described this way, but I went back and did the arithmetic and put it in dollar terms rather than percentage terms. If you look at a $1,000 a month policy, ballpark, reasonable number, if you're in the slightly above the Medicaid poverty level, Medicare qualification level, you'd get about 95% of that paid for by the subsidies. This is really important. Even in middle income at about $50,000 a year, you'd have about half your premium paid for if you were in the exchanges. Exchanges and the subsidies are critical to making this work. And I want to talk about that later, I think, because that's going to be an important touchstone for what the Republican counter to this might be and what it really was. So we'll talk about that a little later. They operate through the exchanges, and the exchanges I've found really puzzling because it's not a big deal. It's just a big website with all this stuff on it to look at. So the exchanges are there, and we need to consider whether they're in fact going to make it or not. And then we have the small employer subsidy, and this is an interesting point because it's a major difference between the Republicans and the Democrats. The small employer subsidy is basically the essence of John McCain's proposal, yet it was never really embraced. And as it came out, it was fairly limited. So the tax subsidy for small employers is just for small employers. It's pretty generous, actually. But it wasn't enough to get the small business people on board, so they've still pretty much been negative with that, and the numbers are pretty big. By the time you look at it, it's about on a $10,000 policy. It could be, say, $3,000 a year. Could be a pretty significant number. So now, where is this thing going to go? Well, now we've got the election, and so the election is a big one. Now, I won't try to prognosticate about that because I don't know any more than you do about where it's going to go. But again, it may cause troubles because the Democrats just can't explain this. And if they could only explain this a little bit better, maybe some more people would catch on and be positive, but they can't seem to do that. I didn't get a laugh out of that. I think that's hilarious. I thought that was really funny. So the elections are critical, but I don't think they'll derail them. The big question is, what are they going to do? At the end of my street, I live in Rocky River, there is an interesting place that has a sign on it that says, "The sweetness of doing nothing limited." I thought, this is so cool. What kind of business has a name like that? Well, it turns out it's a consulting firm that helps Congress to figure with their agenda. Nothing's going to happen. There's still going to be stalemate. They probably won't get around to doing anything. Actually, for those of you who are retired, they make T-shirts that say that on it that they sell to retirement homes and such. I got to get a load of those. I just love to have it. The exchanges are really important. I want to seriously deal with that just a little bit. The exchanges are important, and the various other elements that are in there, I think, are important beyond the exchanges. We'll talk about the exchanges, too. And this is where the part that most people don't even know exists, but I think maybe will the ultimate change and probably will tie back to some of the other discussion items we'll have this morning. Accountable care organizations are really big. They're going to grow like mad, and they're a method for people to continue to do care, particularly for the elderly, for people who qualify for Medicare, but it will also be for businesses as well. Around here, University Hospital is the big one that's actually out of the gate. There'll be others. You continue to bill for Medicare, but if regular rates, but if you hit quality standards that are specified for the enrolled population, and if you drive the cost below the actuarial forecast, you get a bonus. You get a significant bonus, 50% or so of the difference back. This is a huge incentive for people to go play nice in the sandbox, figure out how to reorganize the system, and probably will be one of the biggest social science experiments we've ever had to figure out what works in reorganizing the system. So stay tuned. That will be very interesting. That will happen fairly fast. In the next 3 or 4 years, we're going to see some results out of these because they're out of the box now. The second one, PCORI, badly named, is the Comparative Effectiveness Group. They've got about $10 billion to compare different treatment patterns. And those are going to be interesting. They're going to inform physician practices, but I think they'll also be a part of designing new insurance models, maybe even malpractice suits. There are going to be some interesting data that will come out of those. That'll take a while because it has to go through peer review, literature. The whole idea is to make it scientifically valid. You'd think we did this already, but we really don't. FDA does not do this. The third is called the Innovation Center, and that is basically the process R&D, the D part for the feds to figure out how to do Medicare better. This could happen fairly fast because if something works, major changes in telemedicine, organizational structures to pay advanced practice nurses at a different level and different organizations. Anything that somebody proposes that in fact works can be rolled out across Medicare immediately. So it's a very quick change item. And then the last one is your nightmare. It's the Independent Payment Advisory Board, IPAB, which is if none of the above works, these are the guys that come in and start enforcing lower rates. This is the unelected bureaucrat part of healthcare reform. I always thought I'd like to grow up and be an unelected bureaucrat someday. So These are or the death panel, if you'd like, or put anything else on it. These are the bad guys who are going to come in and tell us how to lower cost, and Congress has to take it. They have 90 days to come up with an equivalent amount, or it becomes law. This is the part that people are worried about. I think, and I'm not going to dwell on this because I want to make sure we get to the other things. I use this framework in my health policy and management class to try to think about what happens, and particularly what the government thinks it's doing, what it's after, what it thinks it's doing, what kind of tools it uses, what kind of assumptions it makes about the real world, and that's sort of straight policy analysis, and then what signals they're actually telling people. Expand, contract, take risks, don't take risks, things of that sort. And as a result of unintended consequences, then what does the government do? Change the policy, expand, contract, broaden or tighten a variety of things. This is a framework that I use to think about unintended consequences, because the health care reform bill will absolutely have unintended consequences, like anything the government does. So the real question in seeing what's coming next is, so what's the reaction to health care reform, both in the real world, where people live and make decisions, and in the policy world? And that's going to be the tricky part. It's a little early to tell, but we'll find some interesting ideas there. Exchanges, I can do the others fairly fast. Exchanges will be a big success, I will propose. And we'll come back and talk about that. The big issue I had with the exchanges is anybody going to show up? Well, the regulations that have actually been written are really good in terms of lowering the level of risk and letting people get in. There will be a lot of competition. Every insurance company will want to be in this game because they're going to make it much lower risk than I assumed, and reasonably lucrative, I think, for the insurance companies. And we've already done this. Medicare Part D is a plan very much like what we've got here. There's going to be good pooling, and then they have these risk reduction things. The big thing, and I'm trying to lead into Mark on this one, is the exchanges and the reform on insurance will change the overhead cost. And I think that'll be important to changing the effectiveness of the insurance business. And so I think we're going to have a lot of people on the seller side, insurance companies. We're also going to have a lot of people on the buyer side. So I would predict the insurance exchanges will be a success. And if you looked at the Wall Street Journal yesterday, even if they don't make it in the federal level, there will be private exchanges. The front page of the Wall Street Journal has an article about private business doing this. It will definitely be there. The subsidies are going to be a big one. Both it's too big and costing us too much money, but also it's too little. We need to do more. Those are going to be interesting questions. If you go back to the chart that I handed out, that subsidy never really got discussed very well, and I think is a legitimate thing. The Republicans, if they got in power, will want to do more here. So I would argue that that will be part of the replace, if they ever got to the replace part of the repeal. And the Republicans will want to expand that because taxes are the way that Republicans like to spread the wealth as opposed to direct subsidies. We will continue to see Obamacare. This is the unpopular part for those who are retired. Because even if it doesn't work, even if it gets repealed, it's going to come back in a variety of ways. The reason why we'll see it is this. Obamacare is not for the elderly. Paul Ryan wants to do this for the elderly. He basically wants the same thing. So it's interesting. And if you look at the numbers, they're pretty compelling. The average Medicare person puts about $65,000 into the bank compounded. So the contributions add up to about 65. But when you look at the typical person, they take out of the bank about 174. That is unsustainable. That can't be. You can't run an insurance company like that, particularly when the number of retirees are going to double and the number of dependents are going to go from four dependents are going to go up to 4 dependents for every 10 workers from about 2. This is fundamentally going to change the nature of it. So we got to come up with a new course of financing. And the place we have to look, it's like Willie Sutton. They asked him why he robbed banks, and he said, that's where the money is. So where are we going to go to get this? Well, the elderly have 2.7 times the net worth, about double the net worth of the rest of us, mainly because of Medicare, because we changed the way that people get old and go into their retirement years. That's going to be part of it right there, why we have to address this. So we're going to do this, and Paul Ryan will lead the way. Even if he's not elected, he'll still be leading the way. He wants to have it, exchanges, all the things you read in the Ryan plan, as much as we know, look like Obamacare. I think this is total irony that we're having him on the other side here. This is actually a picture of a little-known picture. It's the same place as that other one, but I just love polar bears. They're just so cool. Anyway, actually, the last time around, I had well, never mind. So Ryan, I think he's asking the right question. He just may not ever have the right answer. So where are we going to go? Medicare is clearly going to go broke, no question about that. The wealth is in the 65 population, so it'll have to be figured. Have to figure some way to tap into that. A voucher plan really will reduce demand. They're right about that. But the trouble is it can't be just a flat voucher, because then politically it's not going to work, and we'll have lots of issues that will be here. The exchanges really do work. We know market mechanisms work. We already have that in the Medicare subsidy plans, the Medigap policies. We have it in the Medicare drug plans. It's not a big extension to see how this might work otherwise. So we can definitely do that. But the key is, I think, on the supply side. So we've spent all this time on the demand side. The supply side is really important. So how do we pay people for things? That's the universal question. And we really haven't done that, except for value-based purchasing, which is the key word, VBP, that is in the law, has been the law the last several years, and will continue to be, which means if you screw up in terms of quality, you're going to get paid less. If you do well, you're going to get paid more. That's a really big market base. So the bottom line for all this is, how does it pay off in all these other things? Evidence-based care, purchasing, value-based insurance, how we deal with drugs, how we deal with patient experience and quality. I think those are really important issues to deal with. We've come a really long way, but it's not clear where we're going to wind up. This is actually another one of these real finds. I actually got this picture the other day of evolution, and it actually is true that we've evolved from that to this. And so the real question is that where we're going to wind up, or is this the next step in evolution that maybe will be where we'll wind up? I don't know. You guys got to see this, and this is a good one. So with that, let me end it and think about, well, where do we go next? Well, I led into insurance. I might turn over to Mark. He can talk a bit more about the insurance design and what's happening with the insurance market. And I think you're right after this. So,
okay, great. Thanks, JB. So my name is Mark Votruba. I'm in the economics department, as JB said, and some of my research has to do with the functioning of the insurance markets, particularly as it relates to small employers. And so that's why JB asked me to give this part of the talk, because a lot of what's going on with healthcare reform in the insurance markets really pertains to small employers. So what JB had asked me to do was give sort of a description of what does the market look like today. Oh, sure. So what does the market look like today as far as the non-elderly private insurance market, and what do we think is going to change, and how should things look in the future? So that's what I'm hopefully going to cover in 15 minutes. And I don't have any pictures of polar bears. It just didn't seem to fit with anything I was going to say. Okay. So I hope this isn't too small, but the current market for health insurance, as far as it goes to the non-elderly, can be thought of in different groups. So the two biggest populations, or the two big parts that I want to focus on, is the employer group market, and there's two sides to that actually. So some of you might be aware, in some employers who offer insurance to their workers actually self-insure. These are like larger employers. Case is a good example. You know, big insurers big employers will generally self-insure because they can save some money by doing so. And all that means is that they're hiring an insurance firm to administer their plans, but the risk actually stays with the employer. So if your employees have a good health year, you end up saving money that year. If your employees have a bad health year, it ends up costing you. So the risk is with the firm. And there's some advantages to doing that, in the sense that there's this law called ERISA, which exempts self-insured plans from the state insurance regulations that other people have to follow. And so that can be a benefit to some of these employers because they get to design their plans without consideration of the state regs. And also, this is a big one, a lot of states have a premium tax which they use to help pay for uncompensated care in their state. If you're self-insured, you escape that premium tax. It's not huge, but it could be 1 or 2%. So that's a difference. It makes it attractive to self-insure. Smaller employers usually can't self-insure. These are called fully insured groups. All we mean by fully insured is that they're buying the insurance for both for the administrative side of things, but also so that the insurer will take the risk off their hands. So the insurers in this case are the ones who are defining the products. They're the ones who are designing the insurance products, and the insurers also keep the risk in this situation. And another thing that's interesting about this market is there's extensive use of brokers. And the reason why there is because this is really complicated. Insurance contracts can run for hundreds or thousands of pages. And so it's not an easy market for a consumer to interact with. Even if you're somebody who's experienced with purchasing health insurance, it's very hard to imagine that you're going to be able to scour the tens of thousands of health plans out there, read through the thousands of pages that pertain to each of these contracts under each of these thousands of plans, and then pick the best one, right? The only reason I say that is because when economists teach people about markets, we normally start with this fictional world where people can see everything and they know all of their options and they can perfectly understand the price and quality of everything. This is not a market where we should expect those things to be true, right? It's a complicated market. It's hard for people to compare their options. So this is actually the good side of the market, because if you're getting insurance through your employer, you're a pretty happy person because it's a lot better to be there than in the non-group market. So people who aren't offering insurance through their employer end up in the non-group or the individual market. You can see it's a lot smaller, only 15 million compared to 150 million. But here people are on their own. Again, there's extensive use of brokers because shopping for insurance is really complicated. There's also this, I didn't mention this, but there's also tax reasons why it's nice to get insurance through your employer. If you get your insurance through your employer, then there's this, probably a lot of you are aware of this. You basically get a discount on your insurance if you buy it through your employer, and that discount is determined by how much you pay in taxes, because you get to pay for the insurance out of pre-tax earnings instead of post-tax earnings. If that didn't make sense, it's not a big deal, and you can just let it go. But the fact is there's a tax benefit to getting insurance on this side. That tax benefit does not exist for most people in the non-group market, with the exception of the self-employed. So people who are self-employed do get that. But otherwise, you don't get the tax benefit. You're on your own because nobody's helping you, search for a plan. And you're probably going to use a broker to try to find one. But to be honest, most people aren't very successful over here. And this is what I mean by not very successful, is that if you take out the people who are eligible for Medicaid, and you take out the people who get their insurance from their employers, then not very many of the remaining people actually find insurance in this non-group market. If you do the math, less than 30% of the people who don't get insurance from their employers or from Medicaid end up getting insurance in this non-group market. Now, to economists, this seems like a big failure. And the reason why we think it's a failure is because we expect people to be risk averse, and so we think people ought to want to buy insurance. And so the fact that the people who are sort of stuck in this place where they don't get insurance from their employer, they're too rich for Medicaid, but then in the part of the market that's supposed to be functioning for them, the non-group market, they're not very successful, right? They're not very successful at actually finding insurance, when we think everybody should voluntarily be out there buying insurance because we think everybody, for the most part, is risk averse. So it's concerning for economists that they don't. And this, of course, is going to be what leads to this big problem with the uninsured, why we have so many people who end up without insurance. I'm not going to go into a lot of the details here, but I'm just going to lay out what people's general perception is, to people being economists. Maybe we're like non-people, but economists, the general perception of what's going on here. So the large employer group market, meaning those who self-insure, is generally perceived as providing good value for the premium dollar that employees spend. I'll show you some data on that, but what it basically boils down to is, for every premium dollar that gets spent on a self-insured plan, about 92 cents of that, somewhere between 88 and 92 cents of that dollar, will actually go to finance health care. Okay, so which is good, right? If you're paying premiums, you would like those health premiums to eventually go towards the financing of health care. In the non-group market, it's about somewhere about 75 to 80 to 78% of each dollar actually goes to finance health care. So you see there's this big loss where people in the non-group market are paying premiums, and those dollars don't even actually end up financing health care. More than a quarter of those dollars end up financing overhead, things like brokers' expenses, things to a small degree, profit to the insurers, but profit's actually less of the issue than the other costs. So the large group market seems to be functioning just fine. The non-group market basically looks like a mess to economists. And I think to quote unquote normal people as well. It looks like a mess to economists because it's not a market where we would expect people to have an easy time searching. And from years and years of research, we know there are certain implications of that. And I'll just give you the quick story about this. Sometimes you'll hear people talk about search frictions, and this is what they're actually talking about. When people have difficulty evaluating the quality and the price of their different options, right? So if you're in the market and you're trying to compare your different options in the market, so you'd like to compare the quality and the price. Let's say you have a hard time doing that. If you have a hard time doing that, that actually gives some market power to the other side of the market. They don't have to compete as hard on quality and price because the consumers aren't very good at evaluating quality and price. You can imagine how this would work. In the extreme version, if I was completely ignorant and had no way of evaluating quality and price, there would be no quality and price competition. You need to have consumers with the ability to evaluate those things for the competition to exist. The second part of it is if you have people who have difficulty evaluating these things, then the seller has an incentive to spend a lot of money marketing. And here's why I say that, is that if people can't for themselves evaluate quality, then your incentive is to give the perception of quality, right? Because people aren't evaluating true quality, they're going to evaluate the perception of quality based on what you're telling them about yourself. So one thing that we expect, and we see, people see it in their real lives, is that in the market for complicated products, you see a lot of money being spent on marketing. Okay? In markets where it's hard for people to search, you're going to see a lot of money on marketing. I'm going to show you that this is exactly what you see in just one second. But that's economists' big concern about this market. It's a mess because it's hard for consumers to solve their shopping problem. There's other reasons why human beings who aren't economists think that this market is a mess, and that has to do with the things that JB was mentioned, is that a lot of us don't like the idea that people with pre-existing conditions either can't get insurance or have to pay extraordinarily high premiums. Now, the reason why insurers want to charge extraordinarily high premiums to people with pre-existing conditions is not a big mystery. Insurers are not in the business of losing money. If you're an insurer, the only way you want to offer coverage to someone is if you can charge him at least as much as the expected cost of covering them. Well, tell you what, people with pre-existing conditions cost a lot to cover. And so you're going to have to charge them a lot if you're going to sell them a policy and expect to break even. It's just natural, it's just math, right? Insurers want to charge sick people more than healthy people. But the rest of society doesn't feel all that comfortable about it. You see these surveys, and it looks like somewhere around 80% of the country apparently believes insurers should charge everyone the same, right? So people believe that's true. It's not a business model that's going to work in a competitive market. If you were the one insurer trying to be the good guy and charge the low rate to the sickies, you're the insurer who's out of business, right? Because not anyone else is going to follow you down that road. And then, of course, that also leads to problems of coverage being insecure. And what I mean by that is, when we think about health insurance, we think that people want to be protected from these uncertain health risks that they might face in the future. And the fact is, in the non-group market, you don't have a lot of security because if you get hit by a health shock like diabetes or cancer, your rates are permanently going to shoot upwards, permanently, right? So you might think you have protection today because today you're healthy and today you can afford your premium. But you get hit by cancer, next year that's not going to be the case, right? So it's not real protection. It's temporary protection is what you have. So these are the problems that people perceive and that are trying to be addressed. I hope I'm not going too long. So there's a lot of numbers here. I just want to point out something, which is these two lines. This is from the industry's own data. They actually commissioned this report, so it's not, so I think we can trust it. Although it's hard to get these numbers, like I can't get them. But since they commissioned this report, I think they're probably right, because it actually doesn't look that great for them, so I don't know why they would have put it out otherwise. This is one set of numbers I want to focus on. These are the different markets I was referring to. This is the non-group market. It says individual. They mean, non-group market is the same thing. Small groups mostly fully insure. The large groups are mostly self-insured. And these are the numbers I want to show you. Each of these percents refers to the percent of the premium that goes to different things. And in the case of the non-group market, on average, 28% of every premium dollar goes to non-healthcare stuff, right? Now, people look at that figure and they say, out in the political world, everyone curses the insurers, and they're sure that the insurers are walking away with, huge amounts of money. And they're walking away with some money, but here's the profit line. 3 cents of every dollar is going towards profit in that market. This is about what you see for other financial products as well, is that the margins tend to be about 3%. It's not really about profits. Where the big difference is, I didn't point out the difference. If you notice, so here in the large group market, only about 11 cents of every dollar is going towards administrative costs and other stuff. And it shoots all the way up to 28% in the non-group market. And the big difference is not with profits. It's not about insurers taking more in profit. It's really about the marketing costs, especially broker commissions, right? And what is that all about? Well, what it's about is what I was telling you before, is that these are complicated markets that people have a hard time navigating on their own. And so it's a market where you would typically expect intermediaries to emerge. Intermediaries like brokers who can help people find the products that they're looking for. But this is expensive. Brokers aren't free. They're a resource that has a cost attached to it, and that cost is showing up in these lines here. Not a small cost, right? This says in the non-group market, 12.5%. Well, let's add the other marketing part. About 15% of every premium dollar in the non-group market is going towards the marketing of those plans, not even going towards financing healthcare, going towards the marketing of those plans. So if you could find a way to cut this back, you would actually be helping out people in this market quite a bit. And this is really what the exchanges are all about, is that in the way the world currently works now, it's really hard to be an individual in this non-group market, and what the exchanges are meant to do is make it easier to be a person who's shopping in this non-group market. Okay, so that's sort of a critical thing that I want people to take away from this. God, there's a bunch of reforms here that I just listed, and now I'm looking at this list, and it's making me dizzy. But and JB mentioned some of them, but I just want to ratchet through them. So because all these reforms primarily apply to the small group market, that's where the perceived problem is, and so that's where the reforms basically lie. I already mentioned the state-run health insurance exchanges. There's also going to be an exchange for small employers who fully insure, and there's probably a good reason for that. The non-group market is by far the worst functioning part of this world. The world that the fully insured small groups are in is about half as bad. So we're going to have exchanges for both those groups in the future that's supposed to help make it easier for them to shop for insurance. There's going to be minimum medical loss ratios. What this means is that the amount of money that each health plan spends to actually finance care has to be at least 80% in the individual market and at least 85% in the employer group market, which, one thing that this could have an impact on is to kind of be a kick in the pants to insurers that they're going to have to ratchet back the amount they spend on marketing. At least that's what people are hoping. Premium regulation. So this is the part that is intended to address this concern about the pre-existing conditions, folks. So we're going to have community rating, which just means insurers are essentially going to have to charge similar premiums to people regardless of pre-existing conditions. There's also guaranteed issue, which means you're not allowed to turn people down. Okay, so this is a way of making it, quote unquote, fair for people who do and don't have, or for people who do have pre-existing conditions. Of course, if you don't have a pre-existing condition, and with this kind of regulation, you're going to see your premiums go up. Because if you throw all the sickies into the pool, then the expected cost of covering that pool is going to shoot up. So if you're not one of the sickies, you're going to see your premium go up. And this would kick off what economists call adverse selection, an unraveling of the market, because people who aren't sick would see it in their interest to drop out of the market and wait till they get sick before they purchase coverage. Well, since the point of the whole thing is to increase the number of people with insurance, this would be a terrible thing, because you'd end up with fewer people with insurance instead of more. So there's going to be these individual mandates, which are essentially penalties. If you don't get your coverage, then you're going to have to pay some amount, that's not terribly high. In fact, some economists are concerned that the penalty isn't high enough and that we still could have this dropping out phenomenon. But so this is, as JB said, some of this stuff is going to evolve over time because we're going to learn as we go. There's minimum coverage requirements. You almost have to have this, because if you're going to have a mandate, you have to say what it is you're going to mandate. And so they had to define, well, what are we mandating exactly? Well, you have to define, well, what do we mean by coverage? So you had to establish some minimum coverage. They did this for another reason too. There's actually a lot of underinsurance in this country, which people aren't aware of. Is that there's two things here. One is that medical bankruptcies are one of the largest causes of personal bankruptcy. So what I mean by that is people, go bankrupt because of high medical bills. And the other fact, which is really interesting about that, is 3/4 of medical bankruptcies are people who have insurance. They just didn't know their insurance was so crappy. And then when they get sick, they find out, which isn't a good time to find out. So some of this minimum coverage requirements, there's been arguments about it from economists in sort of a paternalistic vein, or anti-paternalistic, we don't need to tell people what their minimum coverage needs to be. But a lot of people are clearly getting coverage that they later find out is not sufficient to help them when they have a real problem. So I'm not too opposed to this sort of idea. I think it could do a lot of good. Now, if you're going to have individual mandates, you're probably going to need to have subsidies for low-income people, because you wouldn't want to make that group necessarily worse off. These are the folks who are mostly going without insurance now. They're too rich for Medicaid, but too poor to afford insurance. We don't want to make them suffer, an additional penalty because they can't afford insurance. And so to help them out, the penalties don't apply to the low-income workers, and instead we're giving them subsidies to try to make it easier. And the subsidies, as JB talked about, are quite generous. So this is a pocket of people who will hopefully be pulled into the non-group market because they have these subsidies and because that market will be better functioning in the future. And then once you have all these things in place, you have an individual mandate, the non-group market is hopefully working better. You're giving these subsidies for low-income workers who are in that world. Well, then there's this concern that, well, what if employers start getting rid of their plans and throw everybody into the individual market? I, as an economist, don't see this as a problem at all. But politically, this was a huge problem because apparently people wanted to be told that we can keep whatever we have now. And the Obama administration wanted to tell people that. And so the only way you could tell people that is if you say something like, well, don't worry about it. The employers aren't going to drop their coverage. And the way you do that is you say, because if they do, we're going to penalize them. If they do, we're going to penalize them. So that's what happened is there's these pay or play rules where large employers are either going to have to provide coverage or contribute to coverage, or they're going to have to pay some penalty to offset any incentive they might have to throw their, to drop their plans and put people in the non-group market. And then once you're going to have penalties for employers who don't offer coverage, well, what are you going to do about these small, low-wage employers? You don't want to penalize them, and the legislation says, no, we don't want to penalize them, just the opposite. We're going to, instead of penalties, we're going to use subsidies for small groups and for low-wage employer groups in order to create incentives for them to actually give coverage where they didn't give coverage before. So as far as how things are going to change, and it's a complicated set of things. They do hang together in a particular way, but I think there's, as JB said, there's going to be a learning process as far as the specifics of where these things are set and whether we set some of these limits correctly, whether these minimum coverage requirements are too tight or too weak, whether the subsidies and the penalties are too large or too small. And I think that these are things that we're going to end up figuring out over time. As far as how things are going to change, this is very crude, depiction of it. But don't expect too much change here. Like I, as a case employee, don't expect this reform to affect me very much at all because we're self-insured. Nothing's going to really change here. In the fully insured groups, one thing that's going to improve there is they should have an easier time shopping for insurance because there's going to be exchanges that help them out. As far as the number of people in this market, my guess is that it's probably going to go up because there's going to be penalties there's these penalties for firms that don't offer or contribute to insurance, which will probably encourage more small groups to offer coverage. On the other hand, I put the negative here because a lot of people are convinced the penalties on employers aren't large enough and that these small employers are just going to get rid of insurance and throw people to the individual market. And I'm sort of sympathetic to that view in one way, which is if the individual exchanges work well, then I think a lot of employers would really like to get out of the health insurance game. I think if you're producing, widgets down in Elyria and you're really good at producing widgets, then that's what you want to do is produce widgets. You don't want to worry about health insurance because that's not where your expertise lies, right? So if you could get out of the health insurance business, you would like to get out. And so it could be that a lot of these smaller employers decide this is a good time to get out. And I personally would be perfectly fine with that because then people could go to these insurance exchanges and find the coverage which is best for them. It really makes no sense for us to get our insurance through our employer anyway, right? I mean, what does that have to do with our health care? The non-group market is going to grow. This is going to be one of the sources of increased coverage. And it's going to grow depending on what happens over here. It'll either grow a lot or it'll grow a whole lot, depending on what the small employers do. The other part that increases insurance rates in the ACA is that the Medicaid thresholds are going to be raised. So there's going to be a lot more people going on to Medicaid, and then those two sources together are going to be where the reduction in the uninsured come from. So that was so that's kind of my quick view of where I see the market now and where I think things are going to evolve after reform goes into effect. Yeah, Mariana.
Hey, you want to click on one more?
What's that?
I click on one more.
Hi, I'm Mariana Carrera, also in the economics department. My area of expertise is both health economics and behavioral economics. And so what I study in my research is how patients or consumers in general choose health products such as drugs, how are their preferences formed, and also how they choose health behaviors. And then I tie that to how doctors can try to figure out patients' preferences when they're trying to figure out what's the right treatment for a given person. So to situate this in a broader context, back in the olden days, you'd call a physician to your house when you were feeling ill. The role of the physician was to diagnose and to treat diseases. In the modern world, it's very different. Thanks to scientific progress, we know a lot more about how to predict what diseases are likely to emerge and how to prevent them before they emerge. So this requires physicians to play a very different role in some ways and to focus a lot more on figuring out how to induce behavior change in their patients when they're trying to recommend either different lifestyles that will be better at preventing illness or encourage them to take drugs that they're not taking because the drugs make them feel better today, but because the drugs are supposed to prevent something from happening in the future. So what sorts of behavior are doctors trying to, behavior change would they try to induce? Getting them to get on a certain medication regimen that might be unfamiliar or difficult at first. Maybe getting patients to monitor vital signs that are necessary for figuring out when attacks or illnesses are likely, or improving their diet. So for all of these forms of behavior change, the doctors really need to understand more about patient lifestyle, patient priorities, and patient preferences than they did, back in the days when it was really more about figuring out what disease is going on and how you can kill that disease. So this is difficult because often patients aren't upfront about their preferences, even when they are in the doctor's offices. A recent study finds that you get more accurate information from patients if they actually go through an automated phone call, hitting different numbers if they've been taking their drugs or not. That's a better way to get accurate response from patients than having doctors ask them these questions in person. So that's kind of the broad context. The specific context I study is prescription drugs. So over the past 20 years, prescription drug costs have kind of skyrocketed as a share of national health expenses. And it's not just because drugs are getting more expensive. It's mainly because drugs are being used for so many different things and serving a larger purpose in prevention of disease. So just to get a show of hands, how many of you are on a medication that you're supposed to take daily and refill repeatedly kind of until further notice? Yeah, a lot of us. So the doctor's choice is a little different when they're choosing a drug that you're supposed to take repeatedly, without checking in with your doctor each month, versus back in the day when they would say, okay, take this, it'll make you feel better, boom, that's it. So the challenge is that the doctors don't find out who's refilling their prescriptions until several months down the line when you end up back in the doctor's office and they ask you. And even then, they might not get the most honest response. So this is a problem there's a larger public health problem known as non-adherence, which is that most people don't continue on these long-term drug regimens that doctors recommend for them. It's estimated that about half of people who should be on chronic medications that their doctor has prescribed don't actually take those medications regularly. And Surgeon General once said, drugs only work in the people who take them. So what does this mean? It means doctors need to the doctor's choice of which drug to prescribe should really be taking into account not just which drug would be best for this patient if they took it every day, but which drug might this patient be more likely to continue taking every day. That might involve the choice between a more expensive drug that consumers see advertised on television and a less expensive drug that's now available as a generic. And in this situation, some patients might prefer the more expensive drug that they see on TV. The TV ads will remind them that it's working for them and that they should keep taking it. Maybe some patients are on more generous insurance plans where the price difference between the more expensive and less expensive drug isn't very large. On the other hand, many patients, in particular lower income patients, will be more likely to continue refilling that drug if they get the cheaper version, the generic version. So studies have shown the copay you pay for a drug affects how likely you are to refill it. But I find in my research that relationship is very small for high-income patients, and that high-income patients can actually value, getting the more modern name-brand drug that they recognize, whereas low-income patients do respond much more to the cost of the drug itself. So the question then is, are doctors able to figure out how to sort these patients between drugs? Are doctors able to make the right choice based on just 10 minutes of interaction with the patient during a visit? I find in my research that doctors do appear to prescribe generic drugs more often to lower income patients, but not right off the bat, not the first time they meet a patient. I find that after they've prescribed more than once to this patient in the past, then you start seeing a relationship where the lower income patients are more likely to get the generic drugs and the higher income patients sort of stay at the same rate since that first visit. So it's some evidence that doctors do try to learn their patients' preferences over time, try to figure out what's best for each one, but it's not always easy. It's not always immediate, and they might not even get as far as the right rate to match what each patient wants with the drug that they actually get. A second problem that I identify is that when there's no generic as an option, it's actually a lot harder for doctors to figure out which drug costs less for a given person. You're probably familiar that your health plan has a specific formulary, has some brand name drugs priced at a lower copay than others, but if you haven't taken a particular drug before, you have no idea what the copay of that drug would be. So this introduces another problem in the prescribing decision, which is that doctors don't know which insurance plan you belong to, what your copays are, and they have to choose in this kind of old-fashioned system where they have to just write down a script for one drug. You take that with you. You don't learn the cost until you get to the pharmacy, and maybe there would have been a cheaper option available, but it's kind of too late at that point. Most patients will fill that first prescription, but then might not come back if it was for one of the high-tier drugs that has a $50 copay instead of a $20 copay. So how can we fix this problem? What are some sort of policy solutions we could think about? I mean, hopefully this is one of the issues that PCORI and these government groups that are meant to evaluate outcomes research are working on. So just to contrast this against other possible solutions, some people say that drugs like statins that lower cholesterol should just be put in the water, because people don't like to take their pill every day, but it's considered to be good for pretty much everybody, so let's just put it in our water. Others have argued, actually one doctor wrote a piece in this, I think it was a little bit tongue-in-cheek, but saying that McDonald's should be required to sprinkle some statin on each hamburger. So setting those more extreme solutions aside, I think that there are better ways that we can kind of modernize the prescribing system. And one way would be to allow doctors, nowadays doctors have a choice between a number of drugs that work very similarly. Yet they have to choose just one of those to write down. And if you don't like it or if it's too expensive, it might be 6 months or a year before your doctor gets a chance to write you a new one. So I think it would make a lot more sense if doctors could write a flexible prescription, or if they could even tell their patients, look, there are a couple different options here. This drug might be expensive, but you could find out at the pharmacy. And if that's too expensive, this other drug should work equally well. It's really up to you. And give a patient's choice from the beginning to switch between 2 or more drugs as they prefer based on their specific payments. Others have suggested that the solution is just for the doctors to observe the cost information and to have a computer system that pulls up the prices of the drugs for each person when they choose a drug. And I think that could help, but I think it could help even more to just give the patient a little bit of choice, let the patient evaluate the options on their own time, let them try one drug 1 month and the other one the next month if it's a set of drugs where that's considered okay, which a lot of these chronic long-term medications are. So another policy suggestion towards modernizing this system is to allow people to request prescription changes through the web, through email. This is part of, I think that email with doctors should be used for much more than just prescribing changes, but it's one example where we have to think about, with the rest of our world, the rest of our daily habits have changed so much towards having everything on our smartphone, being able to do everything through an app, and yet the medical system in many areas is way behind. I know the Cleveland Clinic, for example, has done a good job having people's medical records online. Anyone can log in and see the results of their recent blood tests, see everything on the computer screen, but that's kind of at the forefront of these technology changes. A challenge in that is we have to think about, this goes back to the problem of how doctors are paid when we think about if they're going to want to answer patients' questions by email or by phone when that's much faster than an office visit. Well, if doctors are paid based on the office visits they get, then that's sort of has the other incentive to encourage them to require patients to come in and to actually get a real checkup, even if the only reason they're coming in is to request a different drug or a drug refill. So in the last few minutes, I'm going to talk a little bit about what's the role of employers in this, which is totally different. But if we think about how the modern day healthcare is much more about prevention than it was before, we have to realize that employers have already been realizing their health insurance costs have been skyrocketing, and they've started thinking about ways that they can proactively try to address healthcare costs among their employees beyond just paying for their insurance and paying for their coverage. So you may have heard about the recent trend for employers to introduce incentives for patients to, for example, lower their cholesterol or quit smoking. These initiatives are kind of controversial for many reasons, but that's one way in which employers have been thinking, we have this data and we can use this data to figure out what each of our employees is costing us in their health. Can we use this to incentivize them to make better health choices up front? If you think about what data employers actually have about employees, you realize there's actually a wealth of data there. Employers actually see much more about their employees than doctors see about their patients. If you think about it, employers can tell how many hours someone spends at work, what they're doing at work, and what sorts of risks that might lead to. They see information if people have had a disability that led to workers' compensation. They see their absentee history, so they can tell when employees are sick, are taking sick leave, when that's more likely to happen. They obviously know how much their employees are getting paid, so they might know a bit about the monetary incentives. And they also often know more about what their employees are eating in their daily life than doctors do, right? At least one meal is usually consumed at the workplace, and most workplaces have cafeterias. So some employers, for example, the Metro Health Hospital I'm working with on a project where they're trying to use their cafeteria data and match the cafeteria data to employees, because employees get a discount if they use their employee badge. And so they're saying, well, we have these health assessments and we have this cafeteria data, so we can actually try to figure out, are the people who have higher health costs eating worse at the cafeteria? Are there opportunities for us to either implement incentives for healthier eating or to change the offerings at the cafeteria in a way that would move our employees towards a healthier lifestyle? What's that? Yeah, 1984 is here. So it can be a little unsettling, the thought of losing so much privacy. But in a way, your credit card companies and the things you do online reveal a lot more about you to people you don't see. So it's just a question of how afraid are you of your employer trying to analyze your behavior through all the data that they have. But
interject here. That's all under a protocol, and it's all private information. So they don't see that stuff.
Yeah, it's not tied to individual people.
Nobody
It's all
sees that.
de-identified, of course.
I hope.
But yeah, when we talk about what's next, these are just the areas that I find interesting, which are less about the actual reform and the insurance that's being offered, but more about what are ways to sort of introduce better habits to move people towards healthier lifestyles now that we know more about what lifestyles and what preventive drugs can work to reduce health costs in the long run.
Great. Thank you.
Good morning. My name is Richard Buchanan, and I teach design and management here at Weatherhead, an unusual subject. And I have to say right away that JB is a very shrewd man, because he's assembled wonderful experts in areas of healthcare and insurance, the economics of healthcare. And yet he asked me to come and join this panel. Oh my, because I have such a different perspective. Think about it this way. Suppose you have a car and you lift the hood and look inside at the engine and the pistons and all of the computer chips also. This is the kind of thing that my colleagues study with great care, and we need that kind of understanding, without a doubt. But if you close the hood and get behind the wheel, I'm interested in what people do in this system. How do we act? Now let me ask you, how many of you are experts in how many of you study the economics of healthcare? I want to see hands. There's one, there's two, three. Oh, yeah, I know about you, David. But you're studying design, aren't you? Yes, you are. Now, let me ask another question, and I'm going to pick up, I was going to do this too. How many of you have been to a doctor's office or to a hospital? Oh. Well, my point of view has to do with exactly this. What is the change that's coming? One of the changes we're seeing is a shift toward focusing on the patient experience in healthcare, whether in the doctor's office or in the hospital care. In fact, I noticed that Mark and Mariana also brought up issues of human behavior and experience. For instance, how will consumers know to choose among the choices and options in insurance? How will they know? It'll be a confusing matter, and in fact, marketing will begin to take the place of human reasoning. And in your case, too, you talked about the problem doctors have with patients, understanding, because patients lie. We all know that from House. Patients, I see you all watch this, too. We share some things in common, I think. But it's these human behavioral matters, I think, that are emerging with great significance for us. I have to say it's not got the same economic traction yet, but I would say it's not far behind. In fact, to be very specific about it, one of the changes that is occurring is called HCAHPS. It's a system for measuring patient experience and satisfaction. HCAHPS is the hospital consumer assessment tools. They're assessing providers and system satisfaction. It's a scoring system, and it's a complicated and controversial matter because no one quite knows how to assess the satisfaction patients may feel. But there are some categories, and some of my former students have studied this as well as the ACO. And these scores, in fact, are being used increasingly in the formula of distribution of funds in Medicaid. In other words, a hospital that functions highly in patient satisfaction by the surveys that are being performed gets a larger amount of money. It's not a lot of money yet, not big. Say at the Cleveland Clinic, it could run on the order of $10 or $12 million, which is not much. Nonetheless, it's a signal of something that is changing, the awareness of how people feel about their care. And I have to say we have a wonderful set of hospitals in this area, which makes Weatherhead a great location for my work because I do study patient experience. Using the VA, which is the flagship of the VA hospitals in the United States, great company. We also have Cleveland Clinic, great, recognized, university hospitals, and Metro, of course, has its own functionality in this. But in each case, the patient satisfaction matters are attracting a lot of attention by the administrations. In fact, the Cleveland Clinic has created a unit on patient experience. They now have, I believe, approaching 50 people working in this, trying to understand what makes things work well for patients, what's satisfying. Do you feel frustrated? Why? How can you improve that quality of satisfaction? Now you may think this is a trivial matter. Well, whether you feel good or not makes no difference. The question is the outcome. How healthy are you, and so forth. Nonetheless, think carefully about this. Why is it that so many patients return to the hospital after they've been discharged? Why are those numbers so high? The numbers are high. It's surprising how many people come back to the hospital. I see a head nodding. You know what that's like. We've been looking at the issue of a very small part of the patient experience, namely what we call the leave-taking or the discharge experience, and wondering, has that been designed well enough so that patients leaving understand their medications and the regime that they have to follow? Why isn't that working so well? You know, the doctor comes in and the nurse may or may not show up. The doctor says, here are your medications, here's a sheet, go to it, stick with it. Week later, patient's back in the hospital. They didn't take the medication properly or mixed the wrong ones. What went wrong? Little tiny things like this in human experience, seemingly insignificant. Just little things. And yet, the consequences, great. Well, we think there's greater attention to this, and the movement toward studying patient experience and designing more effective experiences which benefit doctors, nurses, patients, and families. This is the matter that concerns us a lot. I was in Seoul, Korea a year or two ago, and I was invited by the president of one of the hospitals there a hospital called Severance Hospital. Does the name Severance ring a bell? Yes, it does. In fact, it was established 100 years ago by a gift from Severance, the Severance we know and love here in Cleveland. Yeah, isn't it amazing? It really is. It is probably the best hospital in Asia, certainly one of the 2 or 3 best. I went through the hospital given a tour, a really extensive tour. Went through operating rooms, robotic surgery being performed on a brain. I watched that happening. I talked with the doctor. I saw other forms all through the hospital. And I was struck by such a different atmosphere in that hospital compared to a couple of hospitals here in the Cleveland area. I'm absolutely puzzled. What's the principle that organizes that hospital that changes patient experience so significantly? I discussed this with doctors, the head of surgery. I discussed it with the president, some of his staff. And all I can find is that they were established originally as an evangelical institution, sort of a church-related service, but they've kept that core of religious mission. Now, I'm not saying that that's the key to everything, but they have a principle of what they call love, that love is the guide for their relationships with all of their patients. It manifests itself in surprising ways. They developed elaborate information systems, but they're not intrusive in the way that we see them sometimes in the United States. There's not the worry about them there. Well, I won't go into the detail of that, but I spent some time looking at what principles organize different kinds of hospitals in the United States. And there are quite different principles that organize them. For instance, if you think about the VA is less concerned about pay for a particular procedure because their patients are there for life. They see the total patient. And that changes their treatment and how they handle patients in that environment. It changes the way they think. Well, these are matters that are coming more and more to us in the United States. We have a tendency in the United States to look for technological fixes. We want to have the best information, the best equipment, the best instruments, the best drugs, and so forth. All of that's wonderful, and it certainly makes a big difference. But if we can't bring that down to the scale of people and the experience we have in the doctor's office or in the hospital, and I mean this in the details of how we interact, how we share, how we build trust, how we know to follow the medication regime that's been set for us, these matters have huge consequences in the outcome. They certainly do. And so I would say to you that one of the changes that's coming, and you asked us to speak about this, JB, one of the changes that's coming is a gradual focus on what the patient experience is. Now, if you doubt this at all, think about Northeast Ohio, a wonderful region of the country, huge strength and a tradition of industrial and manufacturing prowess and success. We are no longer that kind of country. We are no longer that kind of culture. There was a time when the industries could look to us and say, God, you're lucky to be able to buy a product from me. You're lucky to be able to have my car. They don't do that anymore. They realize that they're lucky if we want to buy from them. More and more that's becoming the case in healthcare. We talked about the choices of insurance, about the satisfactions within hospitals, about the kind of treatment and care. I'll just say that one of our very prominent hospitals in the area, which has wonderful technical prowess, does not fare well in that assessment, and there's a lot of concern about this. Can I give a more pointed edge to this?
It's up to you.
There was a meeting where Toby Cosgrove was asked about, well, you know the quote. He was asked about how doctors feel about patients, and he said, you know, what is doctors' empathy? And Toby's response back was, what's empathy? Now, to his credit, and I'm real serious about this, he recognized the change that was coming. That was a signal that we do care. And he's gone about committing resources, extensive resources, to creating the patient experience unit and looking at other ways for innovation in healthcare. Ah, okay, got you, yes. Well, we know the difference of principles between several of the hospitals in the area. But this is an interesting matter, that the recognition, even in a hospital system that presses the technological success, the ingenuity, and the expertise, still recognizing that the satisfaction of patients rises more and more in our matters. So my group at Weatherhead, and Weatherhead's an interesting place for this, and one of the reasons, hi Patty, I know you got to get to work. One of the reasons Weatherhead is an exciting place to work is that we have elaborate studies of the systems issues and that background information that's so critical. That's the technical understanding. We also at the same time have courses where we try to help our students and MBA students and undergraduates move more effectively to designing for concrete application. It's one thing to have a policy, it's another to see how it's actually implemented. And that implementation is the key. That's where patient experience lies for us. I don't want to take too much time, though. We'll look for questions now, right?
Great. I understand actually that Pfizer is working on this problem that Richard just mentioned, that if they can get the pricing right and get the consumer right, they have a pill to deal with the problems of empathy. So it's a disease, isn't it? It is a disease, isn't it?
Technological fix.
Yeah, I think so. Yeah. Yeah, we're going to see if we can use it. Now we're going to put it in the water at the medical school. See if we can deal with the whole thing. Thank you. We have about half an hour left, a little over half an hour. We can clearly, as you can tell, you ask professors to talk, they can talk forever. But I want to open it up now to the group out here in terms of any issues or questions or follow-up you might have. Anyone? Yes.
I've spent most of my career working with age-blind, disabled, and low-income patients. Yeah. And I've been acutely aware that there's a dichotomy in this country. There's those of us who have always had really good insurance, we're well-educated, we probably take very good care of ourselves, and we're generally more healthy, and then there's everybody else. And what I hear a lot of you talking about really does not, to me, feel like you're including that population, because they're a whole lot more, their behaviors are different, they're harder to take care of, their morbidity and mortality rates are really, really high. So if you could address that a little bit.
Could I speak on that? I got this. This will work. Certainly in the area of patient experience, that's one of the kinds of patients that we try to deal with, and understanding what those particular circumstances are and reactions and needs. That's very much a part of what patient experience is about. Every person is situated differently in life. And how do we adjust our behaviors and interactions? How do we improve the quality of that service? A service design task, services themselves are what are co-produced, what we call co-produced. Unlike a cup that's produced by a factory, services have to be produced by the person who's receiving the service as well as the one delivering the service. And both are active participants in this service experience. And I think that's one of the challenges, to be sure there is the capacity for action on both sides.
Let me just add on the financing side, the aged, blind, and disabled group is usually covered under Medicaid. So if you look at the ABD group, it's a very big group. And actually more of that goes to people in nursing homes than to the welfare mother. So we tend to get Medicaid mixed up. It's much more. So when you think about the financing issues, this is one issue where Medicaid expansion at the state level is problematic, and particularly where the Medicaid block grant proposal, which the Republican would be one of the major Republican things, is at least problematic. If we didn't do the Medicaid expansion, and if we did block grants, it's pretty predictable that we'd have trouble with certain subsets of the population. And I think the aged, blind, and disabled is one that we perhaps would see problems with. So it is problematic, and it's definitely worth paying attention to in the policy debates. Yes. Over here, blue.
I have a question about unintended consequences. One of the things that happened very quickly after, I think in the past year, is that individual insurance companies dropped individual child health insurance because of the pre-existing condition rules. So they're out of that business. So has that put all of, I guess the hypothetical is if they're raised by a grandparent who's on Medicare, who doesn't have health insurance like a normal family, is that driving, did that drive more of those kind of policies into the S-CHIP program, or what has happened with that kind of unintended consequence?
Yeah, so I haven't actually heard that there was a lot of dropping of individual child policies. Then again, in the private insurance market, it's, as far as I know, it's got to be extremely rare that children have individual policies. Most children are covered under their parents' policies. It doesn't surprise me, or wouldn't surprise me, because the pre-existing, the restriction against excluding children for pre-existing conditions has already gone into effect. So the incentive to get out of that market was there, because that's a situation where there was no mandate for healthy children to stay in, but there was rules that the insurers had to charge the same rates to everybody. So it could have been that insurers got out. And so if you say that happened, I would have a tendency to believe it. I just had never heard of it myself. I think what it is a short-term issue, just because the individual mandates haven't gone in yet. I think down the road we're not even going to think about this, because the individual market for children is tiny, and there is everyone's going to be under a mandate to have insurance, and so these children are just going to be rolled into their parents' plans in the future.
Yes.
I had a question. You were talking about patients taking control of their own meds. Okay, with my blood pressure, it's easy. My wife's a nurse. If I'm nice to her, she'll put a cuff on my arm, or I can go down to the drugstore and stick my finger in one of these things. And if, as an engineer, it scares me to put my life in one of these gizmos. But when you talked about statins, and one of the side effects of statins is severe muscle pain that I just can't take the things. I go nuts. So how do I titrate or experiment with different cholesterol meds? I can't go to the pharmacy and get a blood draw, so how's that work?
Well, so I do study statins, and I guess a lot of people take statins, and it's true that that's a common side effect for maybe 10% of the people in the population, and often doctors can tell if you're kind of more or less at risk for it. So I'm certainly not advocating that doctors give everybody like a free-for-all in choosing their medications. But I think that there are, if we gave doctors the option to do this, they might use this option with, say, lowest risk patients who they don't expect to have side effects. And of course, doctors will always tell you, if you have side effects, call me and we'll see. But the main point of my suggestion was that switching between one drug and another based on one being much more expensive should be easier and shouldn't require you to visit your doctor again.
This is one where I think we're going to find some interesting experimentation, because if you the only way now is you go back to the doctor and get the script changed. But if Medicare finds in their innovation center that there are different, say, medication centers you can do, different ways to do it with an advanced practice nurse, for instance, and trying out different things, have a little professional input in it. I wouldn't be surprised at all if we find some innovations around the delivery system on drugs in general, thinking of that as a broader design question, rather than this narrow funnel method that we have right now, everything goes through the doc.
But Tamsuline works okay, because I'm still sitting in this meeting instead of Flomax.
You're just full of... you're just completely full of drugs, aren't you? This is a really interesting thing.
It takes me 20 minutes every morning, wait till you have your adrenal glands removed, then you find out.
Great. We got a doc in the back here. Let's get a doctor's input.
I wanted to say that you're Ms. Carrera.
Yes.
Sorry if I got the salutation wrong. I just want to respond a little bit to his. I think that flexible prescription is a great idea, and frankly, I don't know if you guys have switched drugs frequently, but sometimes the side effects from the same class of drugs are different in an individual person. And I think that's a wonderful idea to allow patients to tailor their medication list. I personally hope that there's experimentation in that way soon. I think it would add a lot of ability for patients to take control of their side effect profiles of their drugs, provided they're the same class of medication.
Thank you, and hopefully I'll talk to you later and we can set up an experiment.
She's good at experiment. That's what she does. Yeah. Who's got the mic? Yeah. Yes, sir. In the front row here.
Cynthia and I are from the most rural of the 50 states. We're from Vermont. We have a governor and a legislature that are unified around a single-payer healthcare system for the future. And the reason for that, basically, is when we look at the complexity of the U.S. healthcare system and its future, we can't relate to that. It's just, we think it's intrinsically inefficient because of its complexity. We'd like to see employers free of healthcare, so our small businesses can compete with the small businesses across the border in Quebec, which we can't compete with now because of the burden of healthcare. So, and we have just barely enough healthcare to cover our population, and all our healthcare providers already collaborate as one system. So basically, we're already at a place where we think, and we're being dragged into creating an insurance exchange, but we really don't want it. We'd like to have one insurer, one healthcare plan for everybody. What would you say to us about our situation as part of the future of healthcare?
Well, I mean, I'll sort of comment on that, on that opinion, which is, I think that there's a good chance that you're right. I mean, so we imagine that markets should work better when there's lots of competition and when that competition is centered around the right things. Healthcare is not a market where we're ever going to expect very much competition. There can be in terms of products that can be sold across state lines and such, but care is local. You're going to have, even in a big city like Cleveland, you're going to have 2 or 3 systems competing with each other. We don't normally think of 2 and 3 as being the right number for competition. There's economies of scale in medicine. There's always going to be few competitors in any given area. Same thing with insurance. There's economies of scale in insurance, and in most local areas, there's a few insurers who dominate the market. These aren't markets that lead to very much competition, and if there's not very much competition, the reasons for relying on the market start getting very murky, okay? Now, that's the positive side, I think, of what you're saying. I think the negative side, and I sympathize with this view too, is that once you let the state take control of this, then you have to worry about how well it's going to do over time, or whether the system is eventually going to get captured by special interests, the people who are inside the system and profit from the way it's organized. So I think those are the 2 competing things that we have going on. And I think in America, our sense has been to try to split the difference, where we call it the market, but what we really have in mind is a market where the government is trying to prevent the worst excesses from taking place. I don't know if that's absolutely the right way. What I'd like to see is some experimentation around that. Yours is probably not the only state where the population would like to go to a single payer system. And I would love to see some experiments like that so we can see, right? So everyone can see. And then the states maybe can make individual decisions about what direction they want to go in.
What town in Vermont do you live in?
Near St. Johnsbury.
Okay. Well, Vermont is a socialist state, as we all know, to begin with. So, what do you expect there? I think it's a fair statement, and certainly there's an interesting. Let me just put a little sidelight in here, because I think even though the healthcare reform bill, as I started off, is basically mostly about insurance, that's antithetical to what Vermont would want to do. And my cousin practices in Vermont. I know it reasonably well. It's a great place. There's some things in the bill that are really interesting, because the ACO model, the Accountable Care Organization model, in my view, basically is tacit recognition that it's too late to use a competitive model the way we might want to think about it in other markets. And when you hear people saying, let the market do it in healthcare, they're nuts, to put it bluntly. The market, it's too late. We let everybody consolidate into these big organizations. There's no real competition going on in Cleveland now in the normal classical sense. We've got insurance companies of which they're natural monopolies, and that's not a great place for competition anyway. It's a very inefficient market, as Mark says. The ACO is interesting because it says Medicare is going to continue just like it is right now. And completely behind the scenes, the Medicare people will find themselves in this new organization called an Accountable Care Organization if they get the plurality of their services from a particular group of docs, primary care docs, that are in this group. You don't even sign up. It's not like Medicare Advantage plans where you have to sign in the line. You're in it. And it's transparent to you. You don't even know it's there. But to the people that are in that group that have formed this new corporate entity, it's got the hospital, the doctors, the long-term care. It's got everybody in it. And anybody that receives money from Medicare, they're counted as part of this whole thing. And you all have to meet these quality standards, which are interesting and difficult and controversial because they're changing over time, but they're there. And if you meet the minimum quality standards and you manage to reorganize the system in whatever way you come up with to keep the readmission rate down, to keep people on their drug regimens in an appropriate way, to do whatever you need to do, you will have a significant bonus given back to you in terms of that savings. I find that to be a very interesting case because in the case of managed care, the plan I used to run, we basically were getting bribed to try to hold down healthcare costs, and then we turned around and tried to bribe the primary care doc to not refer as many people to the specialist because we could pay them a lot of money. That's a pretty hokey way to try to run a healthcare system, really. This one, we're going right to the doctors. And we're saying, you guys figure out how to make this work. Create new social mechanisms, create new contractual arrangements. We're not going to tell you what to do. We're just going to say, figure it out around this group of patients. That's the bottom line. It's not your company, it's the patients. If you can figure out how to handle these patients in a more effective way with higher quality and lower cost, more power to you, and here's some money back to help finance this whole thing. We're not even going to tell you how to distribute it among the docs and the hospitals and everybody else. This is really interesting. This is a grand, so I can't wait to see how this turns out. This is a huge social science experiment that we'll find some really interesting stuff. And what we'll find is completely different designs than we've ever had before.
Exactly.
We're going to find docs sitting down and saying, this is really stupid the way we're handling this. Why don't we try this? Well, how are we going to finance it? Well, we've got $8 million coming in bonuses. That's a pretty good start. That's not what's happening right now. Right now, we're trying to figure out how to pay the doctors more money. But once we figure this out, that's not going to buy us where we want to be. We're going to start redesigning the system. So wait for the next 5 years and watch this. You won't hear a lot about it because it's at the provider level, not at the consumer level, but it's the backbone of trying to change this system. So there's that's why I wanted to make sure we touched on that because I think the healthcare bill is important at the insurance level. Perhaps will really make a difference in this small group and individual market. It should. But if you want to change the system, that's not going to change the system. It's all this other stuff that's going to change the system if it happens. And I think it's got a reasonably good chance of having some good stuff come out that will really work. So anyway, stay tuned. We'll figure it out. Yeah.
So
Rob.
JB, just
tell them what you do, Rob.
Oh, I run a group that provides residential care and aging services to low-income seniors in East Cleveland. And as a provider, we're dealing with two kind of behemoth government initiatives. There's ACA on the one hand, but on the other hand, there's integrated managed care. And it would seem that those two would be conflicting in terms of their objective. I mean, on the one hand, integrated managed care is bribing, as you say, doctors and providers to reduce health care so that we can recover as much of our cost as profit under the capitated rate as we can. On the other hand, as you say, the Affordable Care Act seems to be leaving it up to us to determine what's the best possible care for our clients at the lowest possible cost, which I think are two totally different things. And the question I have is that in fact a conflict? And if it is, how did it happen? And if it is, who's going to win?
I think this is a thing to try to increase the use of psychotropics among healthcare managers to try to deal with this. And therapy really helps, Rob. I think you should definitely go into therapy and help you with these kind of conflict problems. It's life, right? I mean, there are multiple conflicts that are dealing, and it's not by design. But remember, the healthcare bill, basically everything that anybody ever thought of got thrown in there. I'm not kidding. I mean, almost every healthcare initiative you can think of, health policy initiative, got thrown in there with the hope that something's going to work. So it's a big experiment. And there clearly are conflicts. So if you go back to that cycle thing that I put up, and we didn't really talk about it, that's going to be one of the places where that health policy cycle is. We're going to have to really think carefully about it, because there will be some real unintended effects. There'll be some things that say, cut down the amount of health care. Don't spend as much money on drugs, because we spend way too much money on drugs. That's really bad. And at the same time, we're going to have maintenance problems that'll kick people back to the hospital. And we don't want to have that happen. So it's going to be an interesting question, who wins in the horse race? Because we got multiple horses out there. Now, do you want to throw the whole thing out and start all over again? I doubt it. I don't think that's a really smart idea. But will we get rid of some of these things, either politically or because they just turn out to not work? Absolutely. There's no question. There will be significant changes. But I really hope we don't throw the whole thing out, because I think it's a once-in-a-lifetime chance to really try out a whole bunch of things that are important that'll maybe make a difference. But these conflicts are important, I think, and how we resolve them is partly a managerial question. How can I make these things work? Because businesses have the same thing. I want to lower cost, I want to increase quality, and I want to reach out to consumer and marketing, and I want to educate. We got all the same things. So there are many things about management that we can bring in here now, I think for the first time in many cases. But there are also these purely medical, technical questions involved, and then there are a huge amount of consumer issues involved as well. So anyway, good point. Yeah, whoever. Yeah.
Oh,
who's got the mic? Yeah.
Over here.
Where'd the mic go?
Right here.
Oh.
Right here.
Where? Oh, back there. I'm sorry, I didn't see. Yeah, no, that's fine. Go.
It doesn't matter.
Go.
I'm encouraged that you're talking about all these incentives and there'll be all these opportunities to innovate. Could you speak to what are the incentives or mechanisms to try to then diffuse these innovations across different healthcare organizations, or even within healthcare organizations, to get people to actually share what they learn, and that we all prosper, whereas sometimes folks want to hold information and to themselves?
Well, traditionally, most people in healthcare blab a lot. They can't help it. They go out and go to conferences, and so it's pretty hard to have proprietary information, I think, really at the managerial level. Patents for things obviously create an artificial barrier for some things, and maybe some of that will happen, but I sort of doubt it. I think there's going to be pretty rapid diffusion on a lot of this. What do you guys think?
Yeah, you can't hide the way you're organized. Yeah. It's really hard to hide your business processes. Doctors and nurses move around a lot. People are watching what each other does in this industry. I don't think there's any hiding of process improvements that can happen.
I guess I didn't necessarily mean hiding. I meant learning.
Well, yeah,
there's new things going on. So
over
there
here. So there is a question of diffusion, but I think it'll diffuse the way it normally does, which is people go to these conferences and the stars wanna they wanna let everyone know that they're stars, and so the stars are happy to go out and tell everybody.
Well, there's a fair amount. Another one of my lives. I'm on the Joint Commission board, and which accredits healthcare organizations around the world. And we started a thing called the Center for Transforming Healthcare that's exactly got this diffusion in mind. So we have partnerships now with, I can't remember, maybe 30 different major organizations around the United States to try specific things with the whole idea that they collect really good data and then they share it broadly. And hand washing you'd think would be simple. That's a huge one, where central line infections, all kinds of stuff, are because we just don't do basic stuff. That's been very, very successful. Metro's now up to 98% hand washing compliance, which is phenomenal. 60% was where we used to be, believe it or not. And I think you're going to find more of that kind of thing. There'll be more of those kind of sharing of public information, because you want to have a quality image. If you're going to sell it to the world, you want the world to believe that I'm really good. Part of that's secondary. You get a certification as one of the top hospitals to do such and such, or the top, and that's going to have more data behind it, and that then will show up in the smiley face and the multiple star syndrome that actually drives volume. Just a quick case in point. The guys there did a study where they looked at the objective measures of cardiac care, and I hope this isn't too close to home for anybody, but And then they correlate it with the top 100 hospitals, or maybe all the hospitals in cardiac care in U.S. News & World Report. And guess what the correlation was between the top hospitals and the bottom hospitals in these objective measures? 0. No correlation at all. There was no objective data. It's all reputational, okay? Well, that's interesting in itself because it says the way we do quality measures publicly, at least, and for public consumption, isn't very good. That was, and this got a straight article, no big hoopla in Circulation, I think is where it showed up. The interesting story for me, though, is then that the next month, somebody called the Joint Commission, the authors on the study, and said, you know, we saw that article. We'd like to come and talk to you about it. That's very interesting. Could you show us what you did? Now, what that means is U.S. News & World Report then starts picking up more objective measures to use in their study, which then sort of reinforces it. The NQF, National Quality Forum, we have a number of graduates now, or at least 2 that I know of are working. They're producing all these kind of quality indicators that get used in the Medicare payment process and now get used by other people for quality indicators too, the Compass system for Medicare Advantage plans and such. Those are going to get used. Those quality indicators are going to get used, and that has maybe an impact on the market. But even more important, it has an impact on the suppliers. Because now if I think it might have an impact on it, I'm going to start managing to that indicator. When the Cleveland Clinic came out relatively badly, they got a minus for the readmission rate for 30-day readmission rate. It caused, I know we got clinic people here, it caused all kinds of hoopla. I mean, man, running around, what can we do about this? You know, we got to solve this problem. Well, that's exactly what you want to have happen. That's terrific, because then they go in and they solve the problem, make a difference. So it's both, we think about it as a market-based thing, but even more important in my view is it changes the way management and organizations behave. And that's where we change healthcare, is when we change the behavior at the provider level, and we're all about that right now. I think this is just a great period. Stressful period. We're going to sell lots of Prozac to people like Rob back there trying to figure out how to do this, but it's the right thing to do. It makes a difference.
Let me add one other point. You're looking at the kind of mechanism for the transfer of learning, really. And I think you'll see more and more hospital systems having departments of innovation or an innovation officer, usually design and innovation. For instance, at the Mayo Clinic, the Spark operation, where I placed a number of my students, it's a good example of this. But we're seeing more and more of those. And those are the forums for bringing ideas in and bringing doctors, nurses, and others to participate together in implementing and exploring alternatives. So that's the mechanism I think it's going to unfold.
Great. We've got about 10 more minutes here, and I want to keep us on time. So, yeah.
I have a question. I think I'm fascinated going to go back to the drug option where we're giving a patient more options in terms of choosing the drugs they want to take. I think that's certainly from an adherence perspective and actually reducing costs, that's going to be paramount. I think most people don't stay on drugs because of high costs. The real question comes about as you give people more alternatives and choices in their drug regime as they go into it. Many patients are chronic, which means they're on multiple medications, and when they start switching and changing, how do you see the market going where there's more centralized administration of drug interactions and so forth, so that as they make these changes, you have less side effects and with cross-drug interactions and so forth?
Yeah, I think that's an important part too, and that's it, the pushes for electronic prescribing have been mostly centered around that, preventing harmful drug interactions, because it could be difficult for a physician to remember, everything else that this patient's taking, but the electronic systems will actually kind of flag the doctor if they have requested a drug that actually has a bad interaction with something else in that patient's repertoire. So does that answer your question? Or?
Yeah, but where do we see the market going over the next few years? I mean, you're going to see this is going to be a big push, right, to try to reduce overall drug spend, which is probably a big percentage of healthcare bills, right, which is where we're trying to get at. So how would you see this playing out in terms of systems and interactions?
Well, yeah, so it's tricky. So I think the insurers use their formularies to try to both get deals from the brand name drug manufacturers on certain drugs that they give a price advantage to, and then they put a lower copay on those drugs to try to drive patients towards them. So, so I think that system would actually work better if patients could respond more easily to their formulary copays. And so you would hope that that would make, in a way, that's how brand name drug manufacturers compete on price, is through making deals with different insurers to put their drug on a lower copay regimen. So that, I think, should improve. The challenge is, the flip side of that is paying attention to cost also means prescribing more generics when you don't necessarily need an expensive new drug. And there's resistance against promoting too much of that, because then the pharmaceutical companies aren't having enough income to be able to research and develop new drugs. So it's challenging.
Yeah, I think there are a couple things on this. One, I was astounded at how bad the drug market is at the plan level. These rebates back to the plans were very, very large. I mean, big percentage of the drug cost that were surprising. And it was totally, I had no idea they were there. I had to run a company before I figured out how bad that was. And it clearly was designed to bias what you put on your formulary and what your copayment was. It was a complete marketing thing, partly volume, but mostly how big a price break you give them. That is wrong. That is not the way drugs should be sold. They should be sold on efficacy and effectiveness, and we've got to change that. I think the pressure will be great to get rid of that kind of system. It's just not a good system because it biases the market in a way that is not transparent to individuals. So I think we're going to find some pressure on that. Insurance companies are going to start getting pressure, and particularly when you get to the providers that have these major incentives around quality and readmissions and things like that, and it's tied back to somehow people not doing the right thing with drugs, they're going to create some pressure too. So I think we'll see some system pressure on changing that. The other thing, though, it struck me while you were talking is I think there will be an app for that. To be blunt, you're going to have on your smartphone apps. You'll put in your drugs, and it'll tell you all kinds of stuff that you wouldn't know otherwise. So you're going to have more, because this is a patient level thing. Just like we were talking. Some things work well for some people, not others. So what is it? The ultimate might be a full genome. If we find out more about the genome, this is a little bit bigger and longer, but it's clearly going to change the way that drugs are designed and used for individuals. And there's great promise on that. Not immediate, but it will happen faster than we probably think it will.
One more point is, so another problem that's going on right now is drug companies will sometimes send patients coupons to pay for part of their copay. And this is also even more totally distorting the market, because the copay is supposed to help the consumer figure out what's a cheaper drug, what's more cost effective, for the whole system. And when you get the drug company offering to pay for your copay, well, they're paying for your copay because then they're getting hundreds of dollars more from the insurer per prescription. So I think that's kind of started in a sneaky way, and when the insurers realize this is going on, I think there'll probably be some.
Well, I don't know about you, but I had great anxiety about my restless leg syndrome, and I've been taking 5 pills for that, and it really makes a difference. Now I don't even know where I am. I'm just completely out of it. I don't take any pills at all.
Yeah, I had a question. You mentioned you managed a managed care organization. I'm actually an insurance broker, one of the people that you guys want to purge out of the system here. So anyway.
It's no offense to you personally.
No, I know. But my question is the recent changes to Medicaid at the state level, in particular with the dual eligibles, people who have Medicare and Medicaid, and the managed care choices that they have. Can you talk a little bit about how you think that's going to affect the state of Ohio?
I beg a little ignorance on that. I don't think I know enough about what we're planning to do with dual eligibles. But there is an initiative if this is a big deal for mainly people who are in nursing homes that then qualify for Medicaid, so they got Medicaid and Medicare both. And that's a very big chunk of the nursing home population. The whole nursing home population issue is a biggie. It's a real problem. And Governor Kasich has actually attacked that one, surprisingly, because the Democrats never did it. They were excuse me, but they were basically in bed with the nursing homes, and there's some issues about that. He's attacked it. I don't know whether he's attacking it the right way or not. I think there's some issues, whether people are going to have the coverage they need in the nursing homes, but it is a for-profit business, and there's been huge issues with political contributions and all sorts of, it's a real mess. It's just not well done in the past. You don't want to let those poor patients get stuck in the middle. That's the problem. I think that's what you're addressing. Is they really are needy, I mean, by definition, and they're vulnerable, and they can't make decisions for themselves very well, and there's no place for them to go. So you got a real problem. This is one of these things you try to do the right thing, not necessarily it's going to save you money, but because it's the right thing, and I think society has to wrestle with that one. I wish I had a better answer for you, but I don't.
I have a microphone.
Okay, one there and then over here.
Maybe this is for Mark. You had put up a chart that said the future makeup of insurance, and on the right side were all those areas I think that this healthcare reform was trying to address, and it seems to be the drive to just get more money into the system through these individuals to pay the providers. But on those lists that included Medicaid, for instance, with numbers going up and the uninsured getting subsidized, I guess the question's pretty blunt. Where's the money coming from?
Oh, yeah, right. Oh, I mean, that's what was missing from that slide, because JB asked me to talk about the
I'm thinking about like
reforms,
the state of California. It's already sinking by the bow, and they're going to have to get some funding to help match the Medicaid.
Well, so there's a couple different sources, but probably the big one is sort of the hidden one. So I'll just go ahead and say the hidden one first, and the hidden one is that by having this mandate, it's sort of like a hidden tax in the sense that healthy people will be cross-subsidizing the unhealthy people in that market, okay? We could have done that sort of more direct route by having taxes and then directly subsidize the ones who had pre-existing conditions. We chose to do it this way, which I think is because people don't like the word tax, and so we like to pretend we're not having taxes. The other ways that this is being financed is that they're raising the amount of payroll that applies to the Medicare payroll tax that applies to the incomes of higher income people. There used to be a cap. What was it, like 100,000 or 105,000 for the Medicare payroll tax, which has been lifted. So that's going to increase taxes on people who make more money. Then there were these, which I would call side deals, in order to get everybody to sort of
investment income too. Investment income qualifies.
Oh, that's right. So capital gains income.
So it's taxing rich people basically.
Yeah, and then there were these. The drug companies agreed to kick in because they saw some benefits coming to them. The hospitals agreed to kick in because they saw that lower uninsurance rates meant that they were going to be more financially stable in the future, so they were willing to kick in. So there was these sort of side payment deals where there's money coming in from these sectors as well. But it's primarily these higher taxes on higher earning people.
Basically, about 1/3 of the revenue that's going in comes from new taxes, about 2/3 from redistribution among the system. And that was a debate between the House and Senate as to how much new money needed to go in, and that's the compromise they came up with. Yeah.
We started talking about the delivery system. I know we're kind of getting short on time, but about the delivery system. And I spent a little bit of time thinking, I've spent a lot of time thinking about the Massachusetts market, not as much in other markets.
He knows a lot about this. He's a Ph.D. student who knows a lot about this area.
But two things that sort of worry me, and I just wanted your input, or collectively the group's input, on the ability of the delivery system to actually make this change. And those two things are their ability to actually gain the type of information they need across health plans about what's going on to actually be able to make changes in the delivery system from a design perspective that actually looks at care longitudinally from an episode rather than looking at start and stop of hospitalization, and having enough information to be able to make those types of decisions. And the second is around their ability to manage risk. I think when you look at, again, when I looked at Massachusetts, I think a pretty sophisticated healthcare market, very similar to Cleveland. But I think from my conversations with health system leaders there, they're having a very difficult time understanding how they're going to actually take on any risk in these kind of value-based insurance design models that they're facing very clearly in terms of higher costs in their market. I find it interesting if you look at Pittsburgh and other markets where they're at least trying to address this by potentially buying a health insurance company to try to learn how to do this. But I have some serious concerns about whether or not health systems have the capacity to really know how to manage risk, and that we aren't setting up a system for unintended consequences, because I'm not sure that we have the quality measures in place to be able to monitor those types of unintended consequences in terms
Now,
of...
that's a scary comment. He works at the place that comes up with quality measures, for crying out loud.
I'm not speaking in terms of national quality.
Yeah, I
forum.
know,
That's
I know,
my
I know,
own
I know.
sort of off-the-cuff kind of concern, but I guess it's just your own kind of thoughts on this, I guess, from a delivery system, since we spent a lot of time talking about insurance models.
So I might need you to elaborate a little bit. Health systems, have periodically interacted with, say, health maintenance organizations where they were paid under contracts like capitation contracts where the system was under risk. And those, I'm trying to understand what. It's always a tough question because I don't understand what the unintended consequences are that you're referring to, because in the past, healthcare systems have had to manage the risk. If you were, in an independent practice association that took patients from an HMO, then you were under some risk because the patients you attract might have been high cost. And they seem to have been able to manage that risk, but although I'm not exactly sure what that means to manage the risk. So could you give me a sense of what I should be concerned about here? Because it's...
So the way I kind of think about this is from a hospital executive perspective.
Mm-hmm.
Their experience with managing risk is kind of like a bundled payment for a transplant procedure. So we'll design the care in order to make sure that we are delivering the best care for transplant. Now, if we're taking on, in terms of an ACO, we're taking on a group of patients from the commercial sector, from Medicare. First, from an information perspective, I'm not sure that I, as the hospital, know what's going on with all these patients once they're out of the hospital. So this readmission issue, which hit us on the NQF side really hard, because there are a lot of providers who don't know what's going on with that patient once they leave the hospital, depending on who. And the second is, I do think this concern about risk selection, because of the fact that I may not try to take on certain patients if I know that I need to be accountable.
Right. No, I see where you're going. Well, and I definitely agree that the concern about cherry picking or cream skimming, whatever you want to call it, is a real concern. If we start paying people flat rates to handle these episodes of care, then you're going to want to pick the ones who are easy to treat. And there's got to be built into the system some safeguards against that behavior. I'm not as concerned about the original thing you started talking about, which is the risk. If these hospitals were, say, only treating like 10 or 20 people a year, then risk is a real concern. But when you're treating tens of thousands of people a year, then yes, some of your patients are going to end up being money losers for you, and some of your patients are going to be money winners for you. But you should be able to make pretty reasonable predictions once you get a sample size of 10,000. You should have pretty reasonable accuracy about where you're going to end up. I mean, that's the whole basis of insurance, too, is the law of large numbers. And so I think the fact that these are not small entities, they're large, says that, yeah, on any individual case, they're taking on risk, but over their whole set of cases they see in a year, they're not really taking on that much risk. As long as the risk is, can they do it well, right? And that's the problem they're going to need to solve.
We're a little over time, and I need to end this, but just to react, I think one of the questions on this whole thing is you create incentives. Any system we do creates incentives, and it will change the way we behave. That's the whole idea. If we don't understand all those incentives, then we get these unintended effects. And I think what we've done is we've created a whole lot of incentives with this, which will induce people to think of this as a design question and think of it to go beyond one patient, one interaction, beyond one institution and one group of patients, to think of it as a broader system question. That makes it unpredictable almost how it's going to go, but very positive. Because what we will find is people will find ways to cross all those boundaries. They'll do it through virtual organizations, through contracts, perhaps through integration. This might drive us into major things. We may ultimately look like Vermont Incorporated. So we may be going to Vermont to figure out how they got it all to work together, because that's a small place and manageable and a way to make it go. I think we'll find examples that'll be very interesting. And then the question is, how do we move towards that in places where we're not doing such a good job? And that's the education. That's why we're here and why we're doing what we're doing. So with that, let me thank the panel and thank you for being here and for being here.